the moderator who's going to tell you all about a health equity systems approach, and then actually introduce each of the speakers that'll be on this panel. Instead, I'm going to just briefly introduce the moderator, and I'll move out the way and go grab some lunch. So we actually have Dr. Philip Alberti here with us. He actually is the Senior Director, Health Equity Research and Policy at the Association of American Medical College, also known as the AAMC. And there he supports the efforts of academic medical centers to build an evidence base for effective programs, protocols, policies, and partnerships, the 4 Ps, aimed at eliminating inequities in health. And he's been doing that since 2012, really focused on community partnerships, health equity science, and scholarships at the AAMC member schools and teaching hospitals, and really making the case for policies and practices that explicitly have health and healthcare equity as its goal. So please join me in welcoming Dr. Alberti.
Good afternoon, everyone. And thank you, Miranda, for the introduction. I'm so excited to be a part of the series today and this panel where we can talk about what it means to really think about a more systems-based approach to efforts to improve community health and address health and healthcare inequities. So as context, I'm going to tease the idea of health equity systems. So in healthcare, there's been this long conversation about what it means for a healthcare system to become a learning health system, right? Where knowledge generation, evidence, research, evaluation is baked into day-to-day practice for continuous quality improvement and learning in a healthcare setting. So my fantasy for these last 20 years has been, can we actually develop a learning community health system, right, that is grounded in community wisdom and reliant on robust multi-sector partnerships to, again, have continuous learning about what it means to achieve health equity in the communities that we serve. So I'm going to tease it a little bit. I'm not going to give the whole kit and caboodle, but here's at the AMC for the last 8 years or so, we've been working with our members to think about the foundations of such a learning community health system. What could they be? And so first, we have to ground the system in local wisdom. So via robust, bidirectional, meaningful co-partnership with patients and communities. Then we have to explicitly address social influences of health across all levels, right? So patient level social need, for example, I am homeless, that would be a patient level social need. Community level social determinants, which might be my community lacks affordable housing. And then societal level fundamental causes that give rise to that maldistribution of social determinants, which makes patients present with their social needs. So in this case, that would be racism, right? Operationalized through racist building, zoning, lending practices that lead to lack of affordable housing. Then in this system, we have to connect the nodes right, through health information technology. So there's real-time learning, real-time information exchange, and education, transportation, healthcare, public health are connected and organized in their efforts. And then lastly, we have to really live that virtuous cycle of research, evaluation, iteration, and dissemination. So the community can learn from itself and other communities can learn from the work that's taking place where we are doing this, again, learning community health system work. So I thought this would be a useful frame to hear from our incredible panelists today that are either engaged in developing learning community health systems or that are catalyzing learning community health systems or both. And so we are going to hear from some incredible folks. So let me introduce them. I'm going to read their intros. So first, we'll hear from Dr. Newton Kendig. Dr. Kendig served as the medical director of the Federal Bureau for Prisons for many years until his retirement from the U.S. Public Health Service in 2015. In 2017, he joined GW as the clinical professor of medicine to spearhead a criminal justice health initiative for the university. And I neglected to show you his picture, but there he is in real life, and there's his picture behind him. Then we'll learn about some innovative Ward 7 and Ward 8 partnerships from Marissa McKeever and Mary Blackford. And then their slide. It's okay, so you'll see their faces on the screen when they present, but I'll tell you who they are. So Marissa is the Director of Government and Community Affairs for Sibley Memorial Hospital. She's responsible for representing Sibley's local legislative and regulatory interest, overseeing certificate of need applications in DC. and driving community priorities for Johns Hopkins Medicine in DC, including developing strategic partnerships, enhancing community engagement, and expanding community investments, with a particular focus on medically underserved areas of DC. Ms. Blackford is a founding chapter leader of the DC chapter of Women Investing for a Sustainable Economy, or WISE. She launched her most recent venture called Market 7 in 2017, which is an organization that worked with 25 Black-owned businesses in the DC area to create a community market that includes fresh food, lifestyle products, and home items in Ward 7. And lastly, we'll hear from Dr. Chris King, the chair of the Department of Health Systems Administration here at Georgetown University, actually. Dr. King teaches and contributes to scholarship on the creation of equitable systems of care within the context of national health reform goals, and works closely with public and private providers to more formally integrate social correlates of health and standards of patient care. It really is an exceptional panel. So each panelist will have about 5 or 6 minutes to talk about their work. I will then swoop back in to ask maybe 1 or 2 questions, but I am determined to leave at least 20 minutes for questions from you here live with us and folks on the live stream as well. So with that, please, Dr. Kantig.
Thank you. And why was I invited? Well, sadly, we've had decades of mass incarceration in this country. So many of our patients are justice involved, and not just the 1.5 million patients who are in 6,000 jails and prisons in the United States, but the 6 million individuals who are in the community who are justice involved on parole, probation, home detention, halfway houses. Secondly, racial and ethnic minorities are disproportionately represented in our justice-involved patients. If you look at men born in 2001, Bureau of Justice Statistics was able to do this analysis. For Black men, they had a 32% chance of going to prison, Hispanics 17%, white men 6% chance. The glimmer of hope is that there is meaningful criminal justice reform going on in this country in over 30 states and the federal system. So more and more of our patients will be coming out of jails and prisons in the years ahead. Hopefully that will continue to increase dramatically. But for our healthcare practitioners, that means more and more of our patients will be justice involved. So I spent my career working on the inside with the Bureau of Prisons, trying to make a difference in public policy as a U.S. public health officer. And I really felt that I wanted to come to the academic community to see if I could give back to corrections in ways that I thought would be meaningful. And one of those ways is in medical school education. And I think first and foremost, we need a diverse workforce. And I'm very proud of the medical student body and its diversity here at the school. So that's first and foremost. Secondly, we need to introduce our healthcare professionals to our patients. We have a couple initiatives that are underway that we've just started. One is in partnership with Georgetown Medical School. Our first-year medical students go into the Arlington County Detention Facility to provide patient education. Really from the get-go, from the very beginning of their education, they're meeting with justice-involved patients and listening to what their experiences have been with healthcare and lack of healthcare prior to incarceration and during incarceration. We have a medical school elective for 4th years in this Introduction to Correctional Medicine to go into the DC jail, and that's been very positive as well. We're trying to integrate case-based learning into our medical school curriculum, so all medical students have to think about justice involvement and the healthcare disparities that are there. Just in one area of medicine, reproductive health for women, there was an APHA article, Black Lives Matter, claiming a space for evidence-based outrage in obstetrics and gynecology. And just briefly, listen to these statistics comparing Black women with white women. For maternal mortality, excuse my voice, 2 times higher, infant mortality greater than 2 times normal. For cervical cancer survival, lower, endometrial cancer death rate, higher, infertility, IVF cycles completed 85% for white women, 4.5% for Black women. So do our medical students understand? Are they aware of these disparities? And if you're seeing a patient, a new mother who's really depressed with postpartum depression, is it even on your radar that maybe they were incarcerated and their baby was taken away from them during incarceration? Those kind of case-based learnings can be very powerful for our students. In the realm of correctional health administration, I'm very proud that we've launched the first master's degree in correctional health administration for the 6,000 in jails and prisons. They all have health administrators. It's on-the-job training. We're providing that online, and a big pillar of that is reentry. And for our administrators to realize that from the very beginning of incarceration, we need to be thinking about reentry into the community and what are those structural barriers to care. I think I've used my time. My website is in clinical public health in the School of Medicine, which lays out a roadmap of how we're trying to integrate justice health into the 4-year curriculum for medical students.
Hi, everyone. My name is Marissa McKeever, and I'm the Director of Government and Community Affairs for Sibley Memorial Hospital. We affiliated with Johns Hopkins Medicine about 10 years ago, and I joined the organization about 5 years ago. And a big part of a priority that we were really focused on is what is our role as an anchor institution in really defining and being more strategic about our community investments, and how are our community investments really advancing health equity in underserved communities in DC? So we had a specific focus on really redefining what does that look like for our investments in communities in Ward 7 and Ward 8. So at that time, we knew that we needed to build stronger relationships, better relationships with community. We also knew that we needed to build trust. So we set along this pathway of really reframing what community engagement means for us as an organization, and what it means for just our brand, and how we are moving forward with identifying new and stronger community investments. So we started by hosting a community listening tour. And rather than do your typical kind of town hall approach to community listening, we had over 100 one-on-one and small group conversations with residents and in Ward 7 and in Ward 8. So we spoke to seniors, we spoke to high school students, faith leaders, parents. We tried to get a nice diverse mix of individuals to really speak to us about, what does community look like to you? What are your hopes? What are your needs? What are your desires? If you could wave a magic wand and have anything in your community or in your home, what would that look like to you? So of course, as a hospital going into community and asking these questions, we obviously heard a lot about health and wellness challenges in Ward 7 and 8. We also heard a lot about socioeconomic challenges. But one piece that really stood out for us is that community told us they want to be a participatory voice in the change that we all see is happening in the district, and particularly what we see is happening in some of our underserved communities. So as we thought about, well, what's our next steps, we knew that we needed to recognize community as experts in their lived experiences and how they are experiencing health equity, but also how do we pair this expertise with what Sibley does well? About 7 or 8 years ago, we opened up an innovation hub. It's about a 4,000 square feet space that's in our hospital. And we've been deploying this methodology called human-centered design to really design new solutions to deliver better care, to create better patient experience. It's all been focused internally on our campus. But we know that we are definitely had that expertise in innovation and in design thinking. So if we looked at how do we merge the expertise of Ward 7 and 8 and what Sibley does well, we decided to develop a grassroots innovation program that's called Ward Infinity. So through this program, we invite residents and nonprofit organizations that are based in Ward 7 or 8, we invite them to apply to partner with us through a competitive selection process. They go through about a 6-month period where they learn the Sibley Innovation Method, which is essentially our human-centered design process, and then they apply that methodology to develop community-driven, targeted solutions addressing the social determinants of health and addressing priorities of the community. So over the course of that 6-month period, we provide our innovators with funding. very robust technical assistance, as well as one-on-one coaches who have expertise in both design thinking as well as public health subject matter expertise. So we've now had 2 cohorts partner with us over the last two years. We've graduated 17 innovators and residents, and it's been an extraordinary process to see an anchor institution that is, our primary role is to deliver high quality comprehensive healthcare. So to take that experience and partner with community to use innovation and community-centered design, empower community with tools to develop solutions that will be based in their neighborhoods has been a rewarding experience for me personally, as well as for the organization itself. Now, I've talked about Ward Infinity in public areas previously, public spaces previously, but I've never had the opportunity to actually be on the panel with one of our innovator teams. So I'm excited that Mary Blackford, normally I actually talk about you next, but I'm glad that you're here. We also have one of our another innovator teams in the audience, Tamara Stevenson with Team Wanda. So it's been an exciting work. We are continuing this program next year, and I'm gonna let Mary kind of dive into the work that she's been doing to truly advance health equity in Ward 7. Thank you.
Hello, everyone. Good afternoon. My name is Mary Blackford, and I am the founder of Market 7. Our work kind of sits at the intersection of restorative health and restorative economics. One of the first times that I ever felt that there was kind of a difference in the way in which we were accessing food is when I was in college. I went to college at Babson College. It's in the Boston area. And I remember going to the grocery store with some of my friends and walking through with a cart, and they're just like taking things off the shelf and putting it in the basket, and then going to the milk dispenser and getting the first milk that's, you know, right there in the front. And I'm like, that's different. No one's checking expiration dates. No one's reaching to the back to get the milk in the back. Very different experience. And then I came home and I realized for the first time that we really didn't have much to eat in Ward 7. I became a vegetarian, and I quickly had this realization, like, I need fresh veggies more often, all the time. And so I was sitting at home on a Saturday, and I was so tired of taking myself and getting dressed and getting in a $10 Lyft and going all the way over to a different ward just to get something to eat. And I said, there has to be something that we can do about this. Because unfortunately in Ward 7, we're experiencing a food desert, and we have one centralized grocery store in the middle of our community, but it isn't the greatest. And so I asked around to all of the people that you would ask in the city, you know, why don't we have a grocery store? How can we get a grocery store? What's going on? And I kept getting the same answer. The annual median income is too low to support a big box retailer east of the river. And that was devastating to me because I'm a vegetarian, I need to eat. I'm serious about my food. So I said, there has to be another way. And I didn't see a model anywhere in the area that really supported what I thought was a really great idea. And I thought back to my time spent in Ghana. When I was in college, I did a teaching program in Ghana where I taught entrepreneurship to high school students. And I remember in Takoradi in Ghana, there was a centralized marketplace that housed a bunch of different entrepreneurs that had food and things for your house and textiles and fabrics. And I said, you know, we could do that right here in Ward 7. We have a small business community here, and we can bring everyone together to create our own alternative marketplaces. And that's how Market 7 was born. And so we started off doing just a series of 8 pop-up markets in our community over an 8-week period, right on the Minnesota Avenue corridor, which went really well. And then I heard about Sibley and the Ward Infinity program. And so I was like, this is right up our alley. And so during our time in the program, we were able to further prototype our market, test out different opportunities that were in the community to make our market even better. And part of our work was doing a consumer survey where we looked at how people were actually interacting with the grocer experience. And we did a survey, and we found that that 67% of people that are living in Ward 7 are going into Ward 6 to get food. Another 24% are going into Maryland to get some or all of their food. But we had this big need in the community for more fruits and vegetables, and 90% of people that were living in the ward wanted that in the community. And so this idea that the need wasn't there, or that we didn't want it, or people are just not going to go and find it, was just demystified through a lot of our work. And so I'm so proud to announce that this year we are opening a food hall right on the Minnesota Avenue corridor. That food hall is a 7,000 square foot food hall space that will feature a Black-owned grocery store. Thank you so much. That will feature a Black-owned grocery store, as well as 9 other food stall spaces that will represent foods from across the diaspora, because we find that we also need more cultural spaces in our community where we can access food that is familiar to the people that live there. So we will continue our work and continue working with Sibley to push forward our mission to make sure that we are getting the proper nutrients and the proper nutritional health and therapy in our community that we so desperately need. Thank you.
Good afternoon, everyone. Let me do what I need to do here. Okay, that would be me. Thank you so much for the invitation to be here, and thank you all for being here. This is such an important topic, and I'm so honored to be a part of this experience. So my name is Christopher King, and I am the chair of the Health Systems Administration Department at Georgetown University, and my space is around training the future, right? How do we train future health systems leaders around health equity and really taking all that we talk about and putting that into practice? So I have a bit of a different approach. My background and my focus is on hospitals and health systems. So my work is around informing hospital leadership around how do you think differently around health, what it means to take care of patients, right? And how do you go from a medically centric system of care to a health care system? We've done a great job in this country around providing good medical care, but we still haven't cracked the code on how to deliver health care. And so over the past 20 years, 25 years, I've had the opportunity to talk to people all across the country about their healthcare experiences, right? With a health equity approach, right? And so I've been playing around with this framework, and I'm going to share it with you. It's not final. I still need to add some touches to it, but it's very simple. And what I've done is I've looked at trends and what people have told me, particularly people who live in historically marginalized communities of color, around their healthcare experiences. And what I'm working on is a framework for the American College of Healthcare Executives around how do we provide equitable systems of care. And so I'll start with the small bubble. We talk about data collection, like real, race, ethnicity, and language. I'd like to add an additional L to that, location, because we know that so much about a person's health is driven by where they live, work, eat, and play. And so when we think about electronic health records, do we have the capacity to use geocoding technology to understand where people are living and to look at trends in population health to make more strategic decisions and inform our strategic partnerships? We all know about workforce diversity, and it's important to have a workforce that reflects the community that's being served. What does that look like? And so we're working on some tools for healthcare leaders to apply to ensure that they have a workforce that reflects the populations. We also talk about the clinical environment, right? Like, what does it look like in your institution? Does your institution reflect the cultural richness? And I'm so pleased to hear about the work that's being done at Sibley around, preservation of community and culture, because that's so important. Talk about being partners, the patients being partners in the care that they're receiving. But if people are going into institutions and they don't see people who look like them on the walls, the artwork, the music, the magazines, we're not reaching them. And so as we think about health reform and population health management and how we are being incentivized now to keep people well, to keep people out of the hospital, this is a great opportunity for people like me, right? It's like, we got to think differently. And it's causing leaders to exercise new skills or develop new skills around patient experience to be sure that they connect to the populations that they're serving, because we want to keep those individuals well. And also we're trying to keep them out of the hospital. So if you've been trained in the American healthcare delivery system, historically, we want to keep people in the hospital because that's how we get paid. Those days are changing. Those days are gone. Keep people well, keep them out of the hospital, provide services at the community level, and make sure you have an infrastructure to meet the holistic needs of the patients that are being served. We also do a lot of training around implicit bias, unconscious bias, and helping people understand the differences between racism and implicit bias, because those terms get conflated and misused and so inappropriately used. And so some of the lessons that we've learned in working with hospitals and health systems that are really struggling with this is you can't do it alone. You have to know what the assets are in your community, and you have to work with those individuals. We're also learning that before you can go out and talk about racial injustice, racial justice, you got to have your house clean, right? You got to know what's going on in your own institution and be sure that you're all on the same page around language that you're using, approaches that you believe in, because it's an important part of the work. Engaging the whole the community is really important, and community engagement. And again, I'm pleased to hear what some of my colleagues are doing around community engagement. Really shifting power, right? When I was at MedStar Washington Hospital Center, we had a barbershop program. We were targeting African-American men in Ward 5. And I was VP of Community Health at the time, and I was helping our leadership understand that we have to shift the power, right? We can't go in and say, oh, look at us, we're going to save the day for this community. And that's what a lot of folks believe. That's the way they think. We cannot move the needle with that approach. It's really about humility and recognizing we don't have the answers. Who are your leaders in your community? And so we found a wonderful barber named Dwayne Johnson. He had his own shop. He said, I've seen so many men die so many of my patrons die, 1 minute, gee. So many of my patrons die from diabetes, cardiovascular disease. I want to do something about it. And he's the kind of person that we wanted to kind of partner with. And he was the face of the program. We were the background. But it took some time for me to get our folks convinced that this is the approach that we have to have. And so he was the one who drove the program. And then advocating for systemic change, right? You heard anchor institution. There's about 5,000 hospitals in this country. 3,000 of them are not for profit. They have a role in keeping this country healthy. They can't address all of the issues, but they have a very important role. And so as an anchor institution, how do hospitals think differently around their business model when it comes to purchasing, procuring, contracting services to focus on communities of need? And so what I've done, very simple, even at Georgetown in our department, I'm like, we have catering services. Yes, Starbucks, I have a Starbucks cup there. Starbucks and Panera, that's good. But what are the community-based organizations in Ward 7 and Ward 8 that we need to partner with, right? To provide those wonderful treats that we all enjoying right now, right? So that's just one simple way. So that's just a 5-minute spiel of the work that I do. I could go on and on, but I think we'll have questions too. So thank you so much.
So thank you all. And one more round of applause for the panel before we start grilling them. Thank you. So I'm just going to ask one question to all the panelists, and I'm going to be provocative on purpose because I think we have some high flyers here that are doing some incredible work, and I'm particularly pleased to hear the focus on community engagement. And so I'm a community engaged scientist myself. And so here's my question. You know, often we talk about the spectrum of engagement, right? From having a community advisory board that you check in with once every quarter, kind of the lowest hanging fruit, all the way through, we've talked about co-ownership, co-leadership, true partnership. And so that kind of, you know, right side of the spectrum, co-partnership, shared ownership, really demands that the learning is bi-directional. So here's my provocative question to the panelists, right? When you are working with formerly and currently incarcerated folks in the curriculum, how is their input actually changing the curriculum? Or similarly, when you are training folks in the 6 or 8 months that they're going through your human-centered design process, how has that actually changed the process in kind of a reciprocal way? So not just giving the training, but also changing your training based on that community engagement and expertise. If we're really going to make some of these shifts and really walk that power sharing walk, What does that bidirectional engagement look like for your four experiences? The order.
So that's a great question. One piece that I forgot to mention in my initial presentation is we also have an advisory council that provides strategic oversight of the program. And the advisory council is comprised of community leadership from Ward 7 and 8, as well as leadership from the highest levels of DC government. This includes the Department of Health, DC Health, Deputy Mayor for Planning and Economic Development, several offices across DC government. So as you asked this question about, as we are focusing on shifting power to community, how are we also learning from community? We went through a lot of discussion internally around what is this program called. Initially, we weren't calling it grassroots innovation or inclusive innovation or social innovation. It was purely about, let's just pay community to do what they do best and give them some tools to do it the right way. And as we have gone through this process now 2 years, we like to call Mary and her cohort, y'all were the test cohort, because we continue to strengthen the program. As we held our training sessions, we typically meet every couple of weeks. We would always have opportunities to just listen to our innovator teams. And we came to every session and basically opened it up and said, how is your experience going? What can Sibley do better? And it's sometimes it's the small pieces as well. Where are the training programs located? We knew we needed to have co-working space that was in the community, more accessible. Sibley is all the way in Upper Northwest, Ward 3. The distance is just incredible for folks who have full-time jobs, but are also wanting to partner on this work. So locating our training in Ward 7 or Ward 8, providing the right culturally sensitive, culturally appropriate food as well through the program. It's just, we tried to make sure that the program was focused on what do our innovators need the most from Sibley that we actually have control of to make the program as strong as possible. Even in the funding, it's not your typical grant funding where you have to meet X, Y, and Z requirements and fit within the box. This is all about innovation and creativity. So we're funding our innovators as if they are consultants that work with Sibley. If we engage any other consultant, I'm going to pay you the money, you're going to meet your deliverables, and that's that. So we see our innovators as not grant recipients, but they are true consultants who are advising Sibley on how we should be thinking about investing in addressing social determinants of health in the community.
I actually had a transformative experience here at GW with community engagement. I spoke about medical education, but another priority in our Justice Health Initiative has been public policy development. We really felt that the academic community could be a safe place for disparate stakeholders to convene. And I know I have lived in a professional silo most of my career, going to the same professional meetings. I'm about ready to go to San Diego to the American Correctional Association. Correctional administrators tend to go to the same meetings year after year after year and not engage with former inmates or in my situation, incarcerated patients. We decided that a key area of public policy that was very evolving was transgender healthcare. So we convened a closed symposium here at GW in August of 2018, and I partnered with the Transgender Woman Advocate, and we brought together leaders from national correctional organizations with the advocacy community and formerly incarcerated transgender women in this case, to talk about their experiences as a patient in the state and federal system. And, in many cases, very sad stories with the high rates of sexual victimization, a lot of issues around the scope of healthcare services and what is really meaningful for a patient, what is important to them medically and from a mental health standpoint. And it was just an amazing experience because you had leaders at a table in a room smaller than this, talking directly with formerly incarcerated patients to help inform public policy. So that really was a conversion for me on just how that community engagement is so really radically important if you're going to advance public policy and patient care.
So for me, a lot of people like to work with change agents because they're so determined and they get in there and they change stuff up. But I like to work with cause agents, and these are people who are directly affected by the problem that you're trying to solve. So working with Sibley was just such a dream because they really took that mission on full storm. And so I'm taking that into our work as well. One thing that I didn't mention in my delivery was that people in Ward 7 and Ward 8 are dying on average 16 years earlier than places in other parts of DC. And that's alarming to me. And when you look at the social determinants of health around food and food access, and a lot of people don't look at grocery stores as like health service centers, but those are your first health service centers. What you put in your body, that is like your first medical um, position on yourself. And so I work very intimately with the community. We have a community working group, and I was actually surprised. I thought it was going to be like 12 people that showed up to this little working group. We had like 55 people show up. And part of our application, as we're selecting the very food stall incubators that are going to be in our space, along with the grocery store, we're going to have a community voting section of our actual application to make sure that community has a voice on everybody that's going to be having a stall space in our space so that we are fitting the needs of the community.
I want to go back to a time I was with the Consumer Health Foundation, which is a local foundation here in DC, and we had historically focused on funding as a safety net funder, right? So we were there to help people once they fell off the cliff, right? If they were homeless, we would support homeless health services, or if they were they fell off the cliff. But we had a change, right? It's like, do you want to focus on people once they've fallen, which is important, or do you want to go upstream and focus on root causes? And so we went through a process around our identity, like who do we want to be? And we said that we're going to focus on root causes. And then we talked about race and institutional racism and all those things. During that process, we wanted to learn. We took a learning journey. We went into a community. So it's the board members and the leadership of the foundation literally got on a bus and went into a community, and we sat in people's living rooms. And I would encourage any institution that wants to do this work in a meaningful way, go into communities, sit in people's living rooms, listen to their lived experiences. Out of that experience, for us, we changed our whole funding model. And we stopped being bean counters, right? It's like, counting how many people you serve. Really, how are we funding issues that really address root causes? Because what we learned when we sat in people's living rooms and we saw the deplorable living conditions, mold, mildew, roaches, and all those things, we were like, this is where we need to spend our time, because this is unacceptable. This is America, it's unacceptable. So we changed our whole funding methodology to focus on a root cause that was keeping people unhealthy. And it translated into policy, because we in trouble for the management company, because they were taking people's money and not reinvesting in the living conditions, and the apartments were not up to code. And so because of our work and our partnership with legal services, change was made, and that management company invested appropriately in the units, and people are living a much healthier life.
We have about a little more than 15 minutes left, I think, Miranda. So please, questions from the audience.
Now, we're going to move into our closing. Wait, let's see. We're going to move into our closing charge. Yes, indeed. Okay. So when we actually started this series, we had a focus on the what at that time. I'm sorry. Did you have a question? No. Oh, okay. And feel free. I know you have somewhere to go, so you can feel free to. Yeah. Any of our panelists, feel free to go ahead and head on out if you need to. But Tim, make sure you give them their little goodie thank you bags before they leave. Thank you. All right. No problem. No problem. So when we were thinking about the what, we were thinking about that shared language and how to even talk about health equity, and understanding which populations share the greatest burden of unfair, poor health outcomes. And then we focus on the structural level, root causes of these disparate health outcomes, to discuss how everyone benefits when everyone has a fair opportunity at health. We quickly moved to the so what. And that's when we started to explore our own role and how to talk about and teach about these disparities in our classrooms, given the social differences that really kind of cut across our social or our student body. But today is the now what. And there are many ways you can translate health equity into action, no matter your role. So I'm going to review some reflection questions, okay? And hopefully it'll make it easier to translate health equity into action. So here's the first question. The next time that you volunteer a person of color to join a diversity committee or initiative, ask yourself why them and not anyone else. Now, as you're thinking of your, response to that, of course, people of color need to be represented in predominantly white spaces. It goes without, saying. But it's also not the sole responsibility of people of color to teach others about all issues of race and racism, or to be the single champion of all things diversity. The next question I'd like you to think and reflect upon is the next time you create a search committee, consider people of color and people from other marginalized identities and backgrounds. As you look through the candidates and notice there's not really gender or racial diversity, stop the search in its tracks and start over. This time, employ an intentional strategy to diversify the pool, not just hoping that it'll happen haphazardly. And even if you do get a diverse pool, the criteria for competitiveness must be critically reviewed to ensure that it really does reflect the social mission. Otherwise, it'll be, oh, there just wasn't, that many strong candidates type of response, making it a people issue when it's really a policy issue. Another question to consider when seeking out service opportunities for yourself, maybe your students, do you select neighborhoods where you go dining or go for cultural enrichment or where you go for weekend entertainment? If not, and you only continue to select the same saturated service sites in neighborhoods where, you only kind of consider them when it's time for charity, then again, take some time to kind of think about what it means to always be on the receiving end of a service in a particular community. And so why not turn that paradigm on its head and seek out opportunities to really engage in these neighborhoods for long term by partnering with these organizations, these residents, these community anchors on a project of mutual interest, with service being a secondary aim. And of course, invest in those same neighborhoods, in their dining opportunities, and in their in their rich cultural neighborhoods. Shout out to Ward 8 in particular. So come on over to Ward 8. And in this way, the communities largely relegated as a disadvantaged group will be lifted as assets and really help to shape new narratives. Another question to consider for your own research: are you asking enough questions? Does your unit of analysis reflect the historical and contextual background of the work? Do you apply an intersectional lens, realizing that the lived experiences of your participants are highly shaped by where they live and what they do, how they perform their identities, and more? Another question: are you in a position to change how community-based participatory research or educational research is viewed for promotion and tenure? Valuing ethnography and participatory action research and pedagogical writing and reflection, we've talked about reflection often during our time here, will advance what's known about public health and how best to prepare the health workforce. Another question: how have you addressed health equity in your own courses? And not as an added slide, but as a lens for how you and your students talk about social disadvantage and historical marginalization, and for how that definitely shows up in the interpretation of data and the implications that has for policy and practice. So the purpose of these questions, because there are many other questions that I could have posed, but the purpose of these questions is for all of us to kind of take the time to think deeply about how the work of health equity is not someone else's responsibility, but all of us actively can promote fairness, justice and our roles as program administrators, as faculty, as staff, as researchers, as residents. And so not that any of us need any more meetings to attend, but to keep your finger on the pulse of this health equity in the city, you can definitely attend ANC meetings. You can attend any of the public meetings of the Mayor's Commission on Health Equity. And this is just a couple of important forums. Network with others, vote in local and national elections. And let's continue this discussion online. So with that, I'm going to invite the chair of the Department of Clinical Research and Leadership, Dr. Leslie Davison, up. She wanted to share some words. And then I definitely appreciate everyone for attending. Hopefully we can stay connected and continue to build together.
So I think some people who are here for the first one kind of get a little history of how this got started. But we were in a faculty meeting, and health equity is something that we've talked about in the past. And when Miranda came on, talked about it a lot more, but people weren't talking to each other. They were talking across each other because we didn't really know what it meant. You know, if we had a pre-test and a post-test, I think everybody would have a definition of what health equity was and what it meant to them and why it's important to include it in our academics, but also in terms of our foundation of kind of who we are as academicians. And so Miranda and I talked, and I said, you know, Miranda, let's put something together for the faculty and CRL. So we're not talking across each other, so we're talking together. So that was the seed, right? And so I gave Miranda seed, and then she turned into a trees. So she's a seeds to trees person. And so it came from like us, about maybe 15 faculty members talking about it, to this 5-part series that was about faculty and policymakers and physicians and advocates and the community that really needs to be talking to each other. So Miranda's done a great job in terms of thanking our guests and thanking support, but I think we all owe her this huge applause for making this happen. So I want to say thank you. And, you know, I can commit from my department that this doesn't stop here, that it's the next, that there needs to be a next chapter. And I think that it's really kind of about collaboration, not competition, with kind of Sibley and Johns Hopkins and MedStar and Georgetown and GW, that we need to get at the table and really work together to focus. And so that's one of the takeaways from today. And the other one is that next year, Best Boys and Poets will be our caterer. That's another one because of how much they really invest in this in the community. And so I think that by building partnerships with those organizations that invest, we're going to go forward. But this is about saying thank you to Miranda. So thank you for attending.